topic as a meeting. So we have three panelists, but Dr. Shailesh is not there, so we'll take his questions alternately. So the first question for the CNS neoplasm critical care management is, what are the expectations of the patient, family, and clinician when encountering a patient with a brain neoplasm? So the patient might have some expectations, the family has different expectation, and as a clinician, we also have some expectations. Regardless of whom we are talking to, we should have a common plan and we should explain the same prognosis to all of the family members. At times, the patient might be just feeling relief from symptoms. They need clarity about diagnosis. They also need hope for hope for meaningful recovery. What is the outcome? What will be the neurological status? Will he be able to walk? Will he be able to live by his own? So these are important questions for which the family members look at us. They want clear prognosis, functional outcomes, and they want a realistic roadmap. What happens many times, almost all of us, we are very unclear about telling the prognosis. We use medical jargons, we use statistical jargons. 5% chances are this, 20% chances are this, but we have to understand that behind every number is a patient, and for them that patient is most important. So we should try not to confuse with medical jargons or statistical jargons. We aim to define the tumor type, extent, reversibility of the illness, and what are the immediate threats to life. As an intensivist, we look at this. Often there is a gap between the oncological possibility, the oncologist, the oncosurgeon, or radiologist. They might want to do everything, but the physiology does not allow many other things. So we have to draw a balance and communicate the same to the family. At this point, we are doing this as a damage control, as an initial step. And once the patient is stable, I might go for the definitive treatment. So the first duty is to align expectations early, honestly, and compassionately. Dr. Lalita Madam, good evening, and Dr. Gopinathan, good evening. What is your take that what are the family's expectation in a patient with brain tumor, especially when they land in ICU now?
Obviously, with the patient lands up in ICU, there is $1 billion question that happens since both the among the family members as well as the treating team. As you have very well put forth, sir, uh, the priorities, like initially, you need to optimize the patient, you need to stabilize the patient, ensure the homeostasis. Once that is so, probably you need to interact with the family, uh, take it slowly, understand the gravity of the situation, and explain the current situation, how the patient has landed up, need to be optimized, and he needs a complete workup before you. Am I clear, sir? Like, it's echoing here actually.
It's clear.
And you need to do a complete workup, sir, before you reveal a prognosis and draw a roadmap in handling these type of patients. Now, being an intensivist, my role, like most often, we do a shared decision making with the family members. We optimize the patient, we ensure homeostasis, and from there, these surgeons do a workup, and we'll take it from there. Actually, most often.
Thank you, Dr. Gopinathan. Madam, what is your take? How to prognosticate once they enter the ICU?
Hi, question. There's some echoing happening. Can you hear me better? Is there less echo?
Yes. Yes, ma'am.
Yeah, better actually.
Better?
Yes.
I don't know why there's echoing.
Yes, ma'am. We can hear you. Now there's no echo.
Okay, just keep the volume down. So I think that when the family comes, the first thing is a very high level of stress, emotional burnout, financial burden. So basically what they're like, the caregivers frequently want to know, they want clear, actionable instructions. what will happen to these patients when they go back home, if they at all come back, what is the quality of life they will happen, what is the continuing care they might need, and for how long they will need that kind of care. And in our subset where, home care is very expensive, is equally expensive as an ICU care, they want to know whether they can give that kind of, near hospital care at home. So I think it's very important to talk to the families and the caregiver. So I think that's very important. And I think just if we talk to the patients daily and not give them false hope, I think a lot of time the family just wants to hear from us, oh, the patient's going to be fine. That I don't think that's the way to go. We have to be very, very realistic. And it's very important if we can talk with the neurosurgeon or talk with the neurologist on the same platform. When different people come and talk to the family at different times, I think that's where some discoherence happens. But if a multidisciplinary team sits and talks together, I think the relatives somehow become more perceptive. That's my take on this.
Very nicely put, and these are easy things to follow, and we must be doing it, especially when there are different voices being presented
Can
to
I
the
come
family.
in?
Yes, please, Dr. Das, Dr. Parveen.
Yeah, well, I agree with you. Like sometimes I feel, uh, yes, we need to give a clear prognostication, but it is not very easy because it's a complex. Because all patients they are not same. These patients are different. Sometimes we even not clear that whether this patient will survive or not. Number one. Number two, sometimes patient they want hope, then a clear message. If you say bluntly that patient is not going to do well, then they may sometimes they may be aggressive, something like that. They like to hear good things.
Yes.
And thirdly, many times intensivists and the surgeons or the anesthesia and surgeon they are not in the same place, in the same page to prognosticate. They neurosurgeon they prognosticate differently, and we prognosis we do the prognosis differently. So, doctor, yes, what do you think? Like, what is this? How to tackle these hurdles?
Yeah. So the first thing is veracity. We have to be truthful to the family. We have to give the prognosis objectively with all parameters we have. At times, we do not prognosticate in one go. We let them understand the gravity, let them assimilate what wrong is there grossly, what is the risk to life, especially if they are fragile families, young members. So we go step by step. But having said that, we have to be very, very transparent. We should not confuse them. We should not give them statistical numbers or jargons. At the same time, all voices should be common. Surgeons should not speak differently, intensivists differently. They'll talk to nurse, nurse will tell something else. So we should give a common message to the family, which should be very, very truthful. I agree to you. At times we have to give this information in a staged way so that the family understands it might be a high grade tumor with which the outcome is very, very bad and the family is shaken and broken. So at times we do it in a graded manner, but we have to tell it very truthfully and completely. Anything to add, madam or Dr. Gopinathan, on this?
Absolutely, sir. You put the message clearly.
Yeah.
No, everybody should stick to the same page, and you have to take it slowly, gain the confidence of the attenders. And most often we do as a multidisciplinary meetings. And that will sort out most of the and the other issues like documentation. Sir.
Yes.
You need to document adequately and appropriately.
So even the patient might be involved, then they go for tumor boards and then they decide in a very, very congenial way and a common decision.
Yeah,
The
I
new,
think
sorry,
most of the
yes, madam.
time, most of the hospitals they have this tumor board,
Yeah.
and mostly cases are discussed, except the emergency surgeries, which are not ICU. Otherwise, depending upon prognosis, only they move forward.
Yeah. So all major patients with oncology non-acute, obviously they should be discussed in the tumor board. This is a norm, and we all should be following this norm. It should not be a single radiology, radiation oncology, or chemotherapist or a surgeon deciding on the fate of the patient. And the onco intensivist is again a saving grace for all these physicians and surgeons. Um, Going on to the next question, Dr. Gopinathan, can you briefly tell us what are the outcome predictors, including the age, type, and grade of the tumor for a patient with brain neoplasm?
Uh, Obviously, as I said, so like the type of the malignancy is very important. The tumor biology is also very, very important equally. And apart from that, the patient age, his comorbidities, his baseline neurological status, his quality of life, existing quality of life, his wishes as well. Uh, Apart from that, the extent of the tumor progression, various factors actually plays the prognosis.
True. True. Thank you. Dr. Lalita, you want to add something? Or Dr. Das or Madam? Want to add something on this?
Like, do you think like the prognosis has changed over the time with a near chemotherapy, something like that?
Yeah.
And like, uh, what do you mean by prognosis? Do you look at the mortality or like cure, or we were looking at the chronic control disease?
Yeah. So when,
So
yeah, wonderful
yeah,
question. So when we talk about prognosis in a CNS neoplasm patient, we talk about short-term prognosis and the
short and
long-term
long term
prognosis.
prognosis.
Short-term is might be discharged from the hospital, the functional status after the surgery or radiation or chemotherapy, and the survival 6 months. Long-term, obviously, we look at the long-term functional status, return to normal life. These are
Yeah,
the
yeah.
things which we look at the long-term.
If
Dr.
you look at 28-day mortality, that our ICU score, CBRD score, it has a role. Like 28-day mortality. For long-term mortality, like 6 months or 1 year, then the rate of cancers, the receptors type, its sensitivity to chemotherapy, they all come to the play.
Dr. Gopinathan, you want to add something? Dr.
No,
Lalita?
obviously, the mortality, of course, is important. More than that, the quality of life.
Yeah.
That is what, like, many a times, patient might not be happy with being bedridden state.
Doctor, yes, can you lift your mic, please, once?
Yeah. Sorry about it.
Now it's,
Yeah. So while we prognosticate it to the family or the patient, we also have to take care what are their wishes and what outcome do they suspect. Some patients and families are happy having a patient tracheostomy in a vegetative phase. So ultimately, what the family wishes or the patient wishes, we have to respect that. That is again a very important factor which decides the prognosis. Ultimately, they are the deciding force for the interventions we do. So outcomes depend heavily on the tumor biology as told, grade, location and resectability. Is it resectable? Is it amenable to surgery or gamma knife, whatever? Is it amenable to radiation therapy? Is it curable with chemotherapy? So multiple factors, and obviously we are not oncologists, it's none of our business, but we should be aware and we should prognosticate depending on what type of tumor it is. High grade gliomas, diffuse infiltration, brainstem involvement, and metastatic burden. These are worst outcome criteria. Another thing which we should be looking at and documenting very nicely is the neurological status at ICU admission. Because if after surgery, if after any intervention, after radiation, the status deteriorates, which was not expected, then it could be a legal issue also. And if the patient is critically ill with refractory ICP or ventilatory need or multi-organ dysfunction, the outcome becomes very
Obviously, sir.
poor.
Obviously.
Imaging severity is again an important factor. So in short, prognosis is shaped by both the tumor type and the patient physiology. Both decides finally on the outcome of the patient. Yeah. We move on to the next question, Dr. Gopinathan. These patients come to ICU for various reasons, and we must understand and emphasize oncological patients just because they are oncology patients should not be denied ICU admissions. Situation has changed to a gross extent now, but 15 20 years back when we started critical care practice, some senior faculty also they used to deny, although this is oncology patients. So, and there is numerous literature that the outcomes are almost similar, especially short-term outcomes that Dr. Das was pointing towards. So they should be given best intensive care trial, and they should not be just written off because they are oncology patient. We have to practice inclusiveness. Unless they have opted for end of life or palliative care, we should give them the best trial which is adequate for that disease. So my next question, sorry, I took a long time because it is a very important point and we must emphasize that. What are the reasons for ICU admissions in patients with CNS neoplasm, Dr. Gopinathan?
Uh, some of the common indications for ICU admission in these sector patients being, when there is a drop in acute drop in sensorium, the drop in sensorium could be due to seizures or due to perilesional edema or due to electrical imbalance, due to SIDH, CSWs. In these situations, now sometimes these patients have a threatened airway due to drop in sensorium. They might aspirate as well, the respiratory failure. Sometimes due to brainstem lesion, they can have a depressed respiratory drive. So for the need for invasive mechanical ventilation, these patients might need ICU admissions. And apart from these patients, as complications related to treatment, edema second to radiation or chemotherapy causing bone marrow suppression, neutropenic sepsis. Sometimes they present with post-neurosurgical meningitis as well. Apart from that, for post-procedure, post-surgical intervention, these patients are shifted to ICU for monitoring for any deterioration. So for various reasons, these patients are need ICU admissions.
Thank you, Dr. Gopinathan. Madam, you want to add something, or Dr. Das, you want to add something?
Yes, this patient, some patient, they come some region related to the cancer or without apart from cancer. Even you get a patient who has come to us with seizures, and it was cancer was not diagnosed. But later on, you have diagnosed that cancer is a part of the perineal syndrome. Suppose the patient has come with hyponatremia. That time it was not diagnosed, but later on you have diagnosed that now this is a part of the PNS. So sometimes patient may came with some presentation that is related to the cancer, but it was not diagnosed earlier. So we can also get some patient like this.
Very right, very right. So they can even present with tumor bleed, hydrocephalus, as pointed out,
Correct,
and they
correct.
can present with various medical illnesses, which are the routine cause of admission to the ICU. Thromboembolism, treatment-related toxicity, maybe
Treatment out of
chemotherapy
safety.
or onco-related. So there are various reasons for them to be admitted to the ICU. Dr. Lilita, madam, now
Yes.
this patient is admitted to the ICU. What are the expected ICU outcomes you will have for these patients?
So I think with over time and with the way the ICU managements have improved over time, monitoring has improved over time, surgical skills have over time. I think modern data suggests that these patients they have almost comparable outcomes to a general ICU patients. And I think, like you previously just said, that cancer diagnosis alone should no longer be a definitive reason to deny care or deny ICU admission. Like earlier on, we just simply used to write them off, and so now if we look at just post-operative admissions to our ICU, so the mortality is fairly low, and is about 6.6% in specialized neurosurgical ICUs. But if that admission is unplanned, say for an acute complication like a seizure or respiratory failure, then your mortality can go up to as high as 15 to 23%. And the overall hospital mortality for all these unplanned admission is almost 20 to 22% in literature. But the overall 6 month survival for primary brain tumors today after an ICU stay is almost roughly 50%. So that's fairly decent by any standard. But nowadays, it's not just looking at what is the mortality or, you also look at the functional outcome, whether this patient can actually they do they stay stable, they do their functional capacity improve, can they look after themselves after they room. So what we call as the KPS scores. So almost these 77% of the survivors who actually go out of the ICU, and if they get good physiotherapy, they perform well. And there's a studies of primary brain tumors from the US which say almost 41% of these patients, they can take care of themselves, and about 14% really get discharged to a hospice care. But if these patients actually get admitted and require multiple forms of support, say, for example, mechanical ventilation, vasopressors, then their significance is their outcome is significantly worse. Plus, obviously, if these patients are in an actively progressive phase, that it's not that they come with the primary tumor, but if so, those who are newly diagnosed or who have a stable disease obviously will perform better than someone whose disease is progressing very rapidly. And again, if we look at patients who simply get admitted with a seizure or a small infection or something, they'll perform better than someone who gets admitted for a mass effect or brain herniation, or what we call as non-seizure related coma. So those patients obviously will perform much worse.
Yeah. Dr. Gopinath, you want to add something on this? Or
No,
Dr.
sir,
Das?
absolutely like, but,
Yeah. So meaningful recovery, capacity for further therapy, and quality of life are also important outcome predictors, and they matter most rather than the short-term stay. We move on to the next question. Dr. Gopinathan, this question is for you. When the tumor meets the ICU, who leads the narrative? First question is this, and the second follow-up question will be, in a critically ill patient, how do we balance oncology intent and acute physiological priorities? I will give you a context to this. We started Onco Critical Care Unit at Max Saket somewhere around 2007 or 8. And the residents, they were not willing to come here. We asked them, what is the problem? They say we felt burnout, we felt depressed. One side, this is oncology, again outcomes are bad, and critical care, again outcomes are not good. So the example they give, I will speak in Hindi. They give, this is like a neem chada karela. So this is a bitter gourd with added neem on it. So this is a double whammy. Not a good anecdote, but this is the general perception. So how do you balance oncological intent with your priorities as an intensivist?
obviously, sir, given the
Actually, before
situation,
Dr. Gopinath
Yeah,
answers,
madam.
isn't it same whether it's a liver ICU
yes, yes.
or it's a bad trauma ICU or this thing? I
Yeah.
mean, I think we
The
should start
perception,
telling
madam.
residents, yeah. So if you put two things
Yeah.
or three things together, the outcome.
Yeah.
But if good care is given and
Absolutely,
you have
absolutely,
things on
madam.
your side,
Yeah,
I mean, we have to
yeah, yeah.
fight for the
Then,
patient. If
then what happened? The same story. Now we have come back. Then people were so happy with the outcomes because the thing is this: onco critical care has changed the way oncology is practiced now. Dr. Das, Dr. Kaur, they will agree to me. What the situation was 15, 20 years back, now people are hopeful. The oncologists, the oncosurgeons, they have good hope and faith in onco-critical care. So things have changed. Then we had onco-medical ICU. The radiation oncology patients, they were comfortable keeping the patients in ICU, and the sicker patients also they could treat. So that was not a very good anecdote to give, but just to set the perceptions, how do the residents feel and how other people feel. And we should not be giving a taboo to any disease as a educated class of people, but this is the way people behave.
sorry,
Yeah.
Dr. Gopinath, sorry.
No,
No, no,
that
no,
was
that's
right
fine, ma'am. Like,
point,
yeah,
madam. Yeah, yeah.
what you said is absolutely right, ma'am. Like, no, probably as like the passion picks up, once you get
Yeah.
interested, once you see the outcomes of the patients, so that may take some time.
Yeah.
Probably we need to be patient as well. Uh, on the other end, like probably when they get rotated,
Yeah.
in our center we have dedicated ICUs, so we get the people rotated, keep them motivated. So I think those things like might help them to go in the long run. And as an intensivist, like no, we take the lead actually
Yeah.
initially. And when the patient presents in with a decompensated physiological state, no, the intensivist he takes the lead role. He optimizes the deranged physiology. He ensures the reasonable homeostasis. That is very important. Like, okay. Once you reasonably optimize the patients, then probably your oncologist, your oncosurgeons, they step in. They try to, as a team, we try to identify the cause, reversible causes. Like you try to optimize it. On the other hand, like if the patient, as like been discussed earlier, if the tumor is like quite high grade, aggressive, non-resectable category, or advanced age with multiple comorbidities, already has suffered a lot. In these situations, probably we need to consider end of life situations.
Yeah, very right.
Uh, uh, actually, like there is way of looking at these things. If we look at only mortality, then it's okay. But men are mortal. Like some people will definitely die. But
Yes.
can we make his dying process comfortable, dignified, pain free?
Yeah,
One of the outcome of my outcome in the ICU is also to make these people uh, a dignified death,
very
a
right.
painful death, and a comfortable death.
Very right.
So that way, like if we take this outcome also, then you'll be you won't feel burnout, like you
Yeah.
won't feel unhappy.
Very valid point again, and very touching point. So the ICU metrics should not only look at survival. This is the wrong thing what we practice. That is why end of life care remains very, very poor. We must talk out of the box and we should look at metrics, ICU metrics apart from survival, 6 months, 1 month, 1 year. We should look at quality of life and quality of death. Like now, going back to my previous Onco ICU, whenever I meet the clinicians who were working there those days or other administrative staff, they now we meet after say 10, 15 years, they will come and say none of them will give tell us about a good survival. But most of them, the clinicians who had their parents admitted for an oncology, they were so happy with the end of life care. They will always remain thankful for that care which we provided at the end of life. So what they remember is those last few days or hours which we were so empathetic with them. So they feel happy about those moments, and still we meet them, and they say thanks for those last days or last hours which they could spend peacefully with their relatives. Oh, so where were we? We got lost in emotions. So yeah, thank you, Dr. Gopinathan, for your answer. ICU care remains multidisciplinary regardless of what specialty ICU we are practice. Neither specialty should dominate in isolation. We must act as a team and we must give a shared narrative to the family. We should not try to overpower juniors or vice versa. They should not try to overpower because we are working for a common good, which is the patient. And good care begins once the physiology is taken care of first. The anatomy, the lesion, the radiation can wait, but the physiology should take the lead as an intensive. We should be given our right place in the beginning. Once the patient is stable, they can later on take over and do the next
Better to
thing.
avoid the second unit once you leave the daily physiology for a
Absolutely.
long run. It will take
Absolutely.
hit.
Yeah. Absolutely. We have to avoid any secondary injury, secondary insult to all the patients in ICU, oncology or non oncology, infection prevention, empathy, small things, multiple small things. If we do right, the outcome will be good. No big things have ever changed the outcome in ICU, but multiple small things taken care of nicely. Enteral nutrition, infection prevention, early de escalation of antibiotics. Small things work wonder. Thank you. We move on to the next question to madam, the Lilita madam. Now we go on to brain edema because of tumor. Are we overusing steroids in brain tumor related edema? And how to individualize dosing and duration of steroid in brain tumor related edema? Steroids is thought to be a panacea for brain edema. And you give bigger doses, people have this perception, edema will be less. So how to break this myth?
So it is, if you actually look at literature, almost 45% of neurosurgeons actually prescribe to them regardless of the symptoms, despite their own guidelines recommending that they should only be used when it's necessary and it should be used at the lowest effective dose. So if you have a asymptomatic, whether you see the NCCN or the ASCO guidelines, they do not support the routine use of steroids in patients who do not have a neurological sign. And that is even if your images is showing if there's edema on the imaging. But if there are no clinical signs, actually most guidelines now tell you not to use
No,
steroids,
very
number
right.
one. Number two, Your a low daily dose is as effective as a higher dose. And you should also understand all these higher doses actually increases the risk of toxicities without any additional benefit. And the problem is that, I mean, actually, the I don't know how to what whether it's the funny part of it or the bad part of it is that some of these patients are on steroids till they actually pass away, because there's no documentation about weaning, or the person or the clinician who's prescribing it is just too hesitant to withdraw it. So we have to be very we have to follow guidelines. Currently our guidelines tell that if there is edema but there is no neurological symptom, we should not be using it. Now, if there are mild symptoms, then a small daily dose should be given. But if the symptoms are severe, we should give a higher dose, split them throughout the day, and we should de escalate them fast. Or if, for example, the patient is normal and suddenly it's become an emergent situation, we give a higher initial dose like 16 milligrams of dexamethasone, but you should also bring it down. And we should also make sure that while we are giving this, say for example someone is on long term use, maybe for 2 or 3 weeks, we should taper them down very carefully, because that's where your rebound edema will happen, or there'll be a potential. And you should additionally kind of address any problems with adrenal insufficiency. That's the first thing. And always monitor them for hyperglycemia, always look at their bone tissue, because vitamin D supplements and all our bisphonates, where all these patients, if we are giving them for extended period of time, should be given additional calcium and vitamin D. Now, in this era of immune checkpoint inhibitors, we have to be very careful, because steroids are immunosuppressions and they actually diminish the effect of immune checkpoint inhibitors. So we have to be very careful that initially, if you have started them, they should be tapered off timely. They should not be there indefinitely, and every time they come back for follow up, this is one thing that should be looked at very carefully.
Thank you. Thank you for highlighting it very, very precisely, madam. But now Dr. Gopinath and Dr.
I have
Das. Yes, please.
yeah, I have a follow-up query. Like, is this the excessive use of steroid or prolonged use of steroid is because that we are not measuring ICP, or we're not measuring salivary enema. That's why we are using lots of steroid in a preventive or whatever prophylaxis way. Is there any role of non-invasive ICP monitoring, like optic nerve sheath diameter and all, etc., to help to reduce the dose of steroid, or like duration of the steroid?
Yeah, there is a distinct role, sir, but we have to always remember the vasogenic edema and the steroids. Yeah, the role is very, very short duration. We have to target the cause of edema. If steroids work vasogenic edema, it will work for 3-4 days at the most.
Yes.
So we have to target what is the cause. Still, the edema is persistent, ICP high is high. We have to look at other things. What happens is steroids become a background drug, not only in onco-critical care, but in neurocritical care in general also. It should not become a background drug. As madam pointed out, you give it, right dose, right duration, de-escalate or wean it off gradually. So we should be very, very stringent about use of steroids, the
Right.
dosage of steroids. Neurocritical care as such, high dose steroids, unwanted steroids, the outcome are bad. Traumatic brain injury, again, if they use steroids, the
That's
outcome is bad. So we have to be very, very judicious with the dosing and duration, and look at the correctable causes. Vasogenic edema is one component, there is more to it. Vasogenic edema steroids will work for a few days. After that, you have to target the real etiology. Yeah, Dr. Das, anything else to add?
no.
Yeah. Dr. Das, how much time we have? Because we are going little slow. We had good
Uh,
discussion. So
we
let
have
us, we
20
have 30
minutes.
minutes, 25 minutes?
Yeah,
Okay,
20
enough.
minutes.
Enough. That is enough. Okay, we move on to the next question, Dr. Gopinathan. This is for you. ICP control, do you do it protocolized or personalized? And should tumor-related intracranial hypertension follow the standard TBI protocols or a different strategy?
I think the ICP has to be done individualized.
Yeah.
It has to be individualized. And the pathophysiology of tumor-related ICP is completely different and compared to the pathophysiology of ICP-related TBIs. He has predominantly vasogenic edema. And having said that, but still, the initial component of ICP management methods probably you can adopt what we do for TBIs, like your 30-degree head elevation or a neck clip being not being compressed. You do adequate venous drainage, optimal sedation, analgesia. Those steps, like the initial steps, like preventing hypoxia, hypocapnia, and trying to optimize CPP. So these steps are like common to most of the race ICP-related situations. But when it comes to tumor-related situations, I think add on to it, probably we need to consider early steroids, as like ma'am said, like steroids, right dose for right duration. For shortest durations, you need to get to consider steroids as early, because studies have clearly shown that for vasogenic edema, steroids play a significant role. When initiated early, they are found to improve the outcome of these patients. Osmotherapy, not much of role. We do initiate, but not as aggressive as we use for as of like for TBA patients. And hyperventilation should be it's very, very tricky in these situations, because sometimes the tumor infiltrated regions, like there will be compromised blood circulation already. And even marginal drop in PaCO can cause a significant drop in CPP in these areas. So it's very tricky. Now, unless otherwise, like certain situations like impending herniations or ICP, which is refractory to standard of care, do not try to hyperventilate these patients. The rest of the things are almost not much of difference.
Thank you. Thank you for sharing the points. And we also have to remember obstructive hydrocephalus and hemorrhage
Yeah.
as a complication. So as you told, we must have a personalized and a structured approach and should not follow blind protocols as we do in general critical care also. The next question was for Dr. Shailesh, and a difficult question for me, for us actually. When will a surgeon be required for ICP management? I will put this question to all three of you. You can answer one by one. When should a surgeon be called? Now, suppose you have a patient with you or under your care in your ICU, brain
Yeah.
tumor. When will you call a surgeon?
No, obviously, when the ICP is refractory, you have imaged already, there is a significant mass effect, or like when there's an, as already said, so like there is an acute hydrocephalus with significant mass effect, probably in these situations, you can call up, sir, early surgical intervention, either for decompressive craniectomy without the tumor bulking or CSF drainage diversion procedures. Probably right time, you do a surgical intervention, probably you might save these patients, sir.
Yeah. So mass effect with midline shift, obstructive hydrocephalus, hemorrhage expansion, and herniation risk are the triggers to call a surgeon.
Yeah.
As you told, failure of medical therapy, again, we should call the surgeon. And it should be timely, we should not be delaying, because a salvageable condition can become an
That's
insalvageable and
very crucial.
irreversible.
That's very crucial.
Yeah.
Timely surgical intervention is very crucial for the
Yeah.
outcome of this patient, sir.
So
Once you,
yeah, sorry, Dr.
no,
Gopinath.
no, sir, like, no, once you delay, then after there is,
Yeah.
even if you're going to intervene, the outcome might not be that great.
Yeah. So the neurocritical care dictum what we follow is surgery should not be the last resort, but the right resort at the right time. So call the surgeon. Actually, we should call the surgeon earlier. Any brain related issue, let us have an opinion. Multidisciplinary care, nothing goes waste. So call the surgeon earlier. He might have his own understanding. He might monitor differently. He might image differently. So always have their opinion. Thank you, Dr. Gopinathan. We move on to the next question. Dr. Lalita, madam.
Yeah.
Seizures, silence or signal. Is routine prophylactic anti-epileptic drugs justified in all brain tumor patients in ICU?
No, actually, when you actually invited me for this, and I was remembering my time when I was 30 years back when we started doing neurosurgery. Our table used to have hydrocodone, Eptoin. It was must on the anesthesia table. So whether it was required, not required, I mean, it was always loaded and always given. As all of us who are probably from my generation remember that. So, things have really evolved over time. So I think routine prophylactic epileptic therapy is just not justified anymore. And I think current medical guidelines, say that those patients who have never really experienced a seizure, prophylactic use of all our anti-epileptic, it doesn't really reduce the risk of your first seizure, but actually might introduce unnecessarily risk like cognitive impairment, somnolence, dermatological reaction, and actually interacts with a lot of your chemotherapy and corticosteroids, potentially using the effectiveness of cancer therapy. So looking at the current clinical guidelines, whether it's the American Academy of Neurology or the Society of Neuro-Oncology or European Association of Neuro-Oncology, most of them say they recommend against the routine use of prophylactic anti-epileptics if it's a newly diagnosed and it's a seizure naive tumor, and there's insufficient evidence that even in the immediate post-operative period there's and the patient has no prior history of seizure, that it should be given. But having said that, if you can give it for a very short course if you're resecting near the temporal lobe or low grade gliomas where the baseline seizure risk is high. And good neurocritical care ICUs now actually do routine EEG monitoring. So if you detect subclinical seizures, when you should actually initiate treatment, and that is, I think, the way to go now.
Dr. Gopinathan, Dr. Das, anything
Oh,
to add
like
on
any other
this?
high risk category, like apart from these situations, what Madam has spelled out, sir, like, from your experience.
Yeah, yeah. So if what we do, I keep it very, very simple. If the clinical and radiological picture do not correlate, I suspect seizure. If I do not have any alternate source of altered sensorium or encephalopathy, I suspect seizure. Either we do an EEG or we do with an anti-epileptic drug. Ideally, EEG should be done as early as possible, but at times it's later and it might take time. So if you do not have an alternate diagnosis, keep seizures in your differentials as number one diagnosis. Non-convulsive status epilepticus in the medical general ICU is almost 15-20% at times. In a neurocritical care unit, it is much, much higher. So we must identify seizures early, we must treat seizures early, and we must look at the interventions. Has seizure stopped? Because many times it won't stop with a single drug. So we always have to keep these three things in mind: identify seizure early, treat seizure early, and look for recurrence of seizure once you have treated the first onset seizure. So decision to give anti-epileptic or not, as madam pointed out, depends on tumor location, severity, post-operative status, cortical involvement, and EG comes to our rescue. Universal prophylaxis risks sedation because most of them will cause cognition deficit, drug interactions with chemotherapy and other drugs, and false reassurance. A patient is on anti-epileptic unnecessarily and there is some seizure activity, we are bound to miss it. So it is has to be again justified and very, very judicious. And most of the time, seizure in such a brain tumor patient, it is not a sentinel event, but it is a signal of something going grossly wrong. So look at seizure as a physiological indicator that something is going grossly wrong. Yeah. We move
Thank you,
on to
sir.
the next question, Dr. Shailesh. There is a question in the chat box. We must take that question, then we will come back here. Dr. Anudita Gupta. She asks, most of the time surgeons complain why intensivists did not inform about drop in GCS, how to exactly understand when to inform the surgeon, and subsequently she asks, for surgeon patient GCS always improves post surgery, so it is difficult to convince them if there is a drop in GCS or not. Dr. Das, this question is for you.
It's very complex actually.
Yeah,
Uh, why intensivists did not inform drop in GCS? I think we should inform them about the drop of
yeah,
GCS. There is no doubt about that. Why not to inform them?
yeah,
And the patient GCS always improve post surgery. This is I leave it to you, Dr. Yes, to answer this.
yeah. So best is whatever you see, you document. If you have confusion, you ask your colleague, junior, senior nurse. you must have a common ground. You should not, one person is writing GCS 7, other is writing 11. That will bring everyone in trouble. So we have to speak the same language and do the truthful documentation. We should not be doing false documentation, neither we nor the surgeons. But the question is very apt. So we should be doing it what is there on the score. We should be documented that only. And any gross change in GCS must be informed, whether it is a neurologist or a neurosurgeon or a senior intensivist. We must inform it. There is no other way, because it could be again signaling a big damage. So do not underestimate GCS. Always document well, document in a similar way. Pupils also. If there is doubt, again ask your colleague, junior or senior or a nurse, and corroborate your finding. Do this work. Pupils try to have now pupillometry or an ultrasound probe. If you cannot have a pupillometry, you can have an ultrasound probe on the eyelid and then size it. At times, post-operative patients, there is so much of edema, you cannot see pupils. So do it with ultrasound. But objectivity and reproducibility is must in GCS and pupil charting. So next question was for Dr. Shailesh. What defines the right timing for neurosurgical intervention in an unstable neuro-oncology patient? I will just set the tone, then you all can answer it. So the right timing balances the neurological urgency against the physiological preparedness, as Dr. Gopinathan already pointed out. If the lesion is causing imminent herniation, refractory ICP, or acute deterioration, surgery must proceed despite instability. Patient will get stable after the surgical intervention only. If instability is predominantly systemic or because of a medical cause and reversible, obviously you optimize the patient for surgery to improve the safety. So the decision hinges on whether delay adds clarity or adds injury. If the insult is because of a surgical reason, it is amenable to surgical repair, please do it as early as possible. Otherwise, try to optimize the patient. Timing is not about my convenience or a surgeon or a radiation oncologist convenience. It is about preserving salvageable function and optimizing the patient before we venture into any intervention, neurosurgery or radiation or anything else in ICU. Please, you can add, Dr. Gopinathan, Madam, and Dr. Das.
Very well said, sir. As you said, like, the optimization of the hemo, I mean, the physiology takes at one end. As I said, the more you're going to delay, if it's going to add up to the insult, then there is no point in delaying actually. You need to do it, you have to do it parallelly as well. The take is pretty clear, sir.
Yeah. Madam, anything to add?
No, no, I think you said it very well,
Yeah.
that we have to differentiate what is really causing the problem. So obviously, if you're looking at a completely, you're looking at infection causing a problem, or if you're causing hypovolemia causing a problem, or if you're looking at other problems. So those have to be treated parallelly. But if it is actually the brain problem causing your hemodynamics to go haywire, then obviously that problem has to be rectified. Unless you don't take, as they say, source control. And if you don't do that source control, you're not going to have an outcome, no matter what you do.
Yeah. And nobody else understands surgical urgencies as good as Dr. Lalita. The reason many of you might not be knowing, because Madam's father was a great surgeon,
Oh, no, no, that's
Dr.
okay.
Mitra.
Nothing to do
And
with that.
so,
It's just that I've seen it in ILBS.
yeah.
I've
Now
seen
you have
it
seen it
in
through
the
ages,
liver
then, well,
hospital. I've seen it in transplants. I've
yeah,
seen it in trauma.
everywhere.
I mean, if you do not take care of the primary problem, there's it's pointless. It's a fight with us every day. You have a leak. You have unless you don't put in their pigtail and get rid of that sepsis, that patient's just going to keep spiking fever. So
Yeah.
source control is something that's we've been inherently taught. So if
And as we do in trauma or at times in sepsis now, this could be staged, not the definitive repair, not the tumor resection in the first go, just EVD or some CSF drainage, and then we later on go on to the definitive repairs. Depends on the physiological parameters. Dr. Gopinathan, we are nearing the end, and this question is for you. Ventilation versus perfusion. It's a tightrope walk, we all understand. How do you optimize ventilation without compromising cerebral perfusion in a tumor related raised ICP?
It's very, very tricky, sir. As I said, like, on the one hand, you need to maintain the CPP. On the other hand, as I already mentioned, like if the ICP is very refractory to a standard of therapy, then obviously you're supposed to do a controlled hyperventilation therapy. The word is pretty clear. You need to do a very controlled hyperventilation therapy, taking very, very strict measures not to get a PSCO2 less than 30. Maximum go up to 30 to 32. But as I already told you, you have burnt out all your standard measures, you have initiated steroids parallelly, you are getting ready for surgery. The patient has got an impending herniation, then probably you can consider controlled hyperventilation therapy without compromising CPP.
Yeah,
That's very, very important, sir.
very right. So controlled hyperventilation for a short-term rescue
Yeah, for a short
and
term
not
only.
Yeah,
That's a
progression.
bridge
yes.
Yeah.
therapy. Yeah.
And sedation, synchrony, and hemodynamic support are again important while the patient is on ventilator.
Yes. Yes.
Thank you. We move on to the next question. This question again was for Dr. Shailesh. Imaging urgency. In an unstable ICU patients, how do we prioritize repeat imaging versus clinical monitoring? Anyone can answer this question.
Yeah.
Well, I think a lot of good critical care units have started getting the revolving CT machine, which is the head CT machine, which is there in the ICU. So the patient doesn't necessarily need to go down. I know Medanta in Delhi has one in their liver ICU. So all your ACLFs now get their imaging done within the ICU itself. So if an institute can kind of afford it, but what doesn't mean that every patient moment they see a slight change in their GCS, we rush them down. Probably we worsen them as we keep moving them. So actually, to what Gopinath sir was saying currently about during mechanical ventilation, even a basic ICU care, a loud ICU, and constantly changing them and turning them and doing all kind of movements and constant suctioning, all those little things go a long way in maintaining the cerebral perfusion. So imaging is same. Your clinical parameters, if they're just very minor, it doesn't mean every time you rush them down and you have to take obviously keep talking to the surgeon. So like one of the questions that was there, that when do you tell the surgeon? So fine, yes, they are the primary team. If when you see there's a drastic change in some kind of a parameter, they should be informed and leave it to their wise decisions if they really want that imaging or not, and if that transport is going to hamper the patient or not. Because a lot of institutes will not have a transport ventilator, and then you see finding it with that 2 liter bag, and then they are pressing 2 liters into the patient's lung, and your cerebral, your brains goes for a toss. By the time they come back, you have a completely different scenario.
True.
So nobody understands. You just need to literally ventilate the patient and not give them 2 liters with two hands while going down to the IC to the imaging department.
Very rightly put. So we had a medicine professor, Dr. Rajan, S.K. Rajan, in our MBBS days. He used to say, imaging should answer the clinical question and not satisfy clinicians' anxiety. So we must be wise. Any deterioration, look at the patient, look at the clinical parameters, non-invasive, point of care testing. Unstable patients, you try avoid transporting, especially when they are in the phase of acute illness. One stable, probably you can do. So transport should never be trivialized in an unstable patient. Look at surrogates, look at non-invasive point of care, ultrasound or Doppler or TCD, whatever is required. So imaging should be done if it informs action. If you think and the probability is very high, then you might safely transport, and a senior clinician should be accompanying the patient for such a transport. And the consent should
That's
also be
right.
taken. If you want to transport an unstable patient, you must take a consent and document it very clearly. This is the reason why we are transporting the
And the
patient now.
benefit,
We move
yeah, when
on
the
to the,
benefit
yeah,
outweighs the
please,
risk, as
sorry.
you well said, and if the imaging
Absolutely.
decision is going to give a drastic change in the outcome of the patient, and as I said, like probably reasonably optimize the patient with the given gadgets and team, and with an appropriate consent from the attenders, patient
Yeah,
attenders, probably you can take a risk, small risk, and go ahead and do an imaging and ensure that the physiologist is not dealing grossly.
yeah. And stabilize, then do the needful whenever patient
Yes.
stable. So the next question, Lalita ma'am, thrombosis paradox.
Oh,
With, yeah, high VT risk in brain tumors, most of them, and how aggressively we should anticoagulate. Obviously, this is not a simple yes or no question, difficult and daily assessment. What is your take, madam?
So I guess our strategies, probably anticoagulant strategy, should depend whether the your intent is prophylactic or if you are giving it therapeutic for a confirmed clot. And then your aggressiveness actually will be tailored based whether that is that tumor likely to bleed and what is the patient's current clinical stability. So again, if you go back to guidelines, they say that you should start pharmacological prophylaxis even 24 hours after a craniotomy, provided your hemostasis is stable. And if you have a patient who's been hospitalized for an acute illness and they're likely to be immobilized for a fairly long bit of time, they should be started on anticoagulants. But now, if you're going to give that for an established VT or something like that, one should understand, and that is after surgery, mind you, that if one has to anticoagulate such patients 48 after a surgery, that actually increases the risk almost by 8 or 9 times. So in those cases, it is recommended that you wait for 7 days, depending upon what is the urgency or what is the surgical site. And when you talk about surgical site, that means whether you're doing parenchymal resection or it's an extraaxial surgery. So that is basically. But what else? What one should also kind of remember that there are certain high risk tumors, like if you have metastasis from a melanoma, RCC, thyroid cancers, choriocarcinomas, they have a very high spontaneous bleed rates.
Yes.
And so in these cases, you have to have a little bit more conservative approach, and one might need to use an IVC filter in an acute phase. And obviously, we'll have to be very careful if, say, for someone is on a chemotherapeutic agent and you have dropped their platelet count to less than 50,000. Then another thing, you have to be very careful that if there's already an existing hemorrhage, about maybe more than 10 ml, they significantly can expand once we start anticoagulation. And like I already said, that if you are if the patient has had a parenchymal resection, they will tend to bleed more. So you'll have to be careful. But you can start antiplatelet, anticoagulating therapy on someone who's had an extra axial surgery. And we should also be very careful, let's say, for example, if they are on other antiplatelet therapy or they are on visasumab or any of these patients, like patients of I think glioblastoma, who have a higher tendency to bleed. So these are some certain subset of patients we have to be very careful, because they have a higher tendency for spontaneous bleeds.
Want to add something, Dr. Gopinathan?
No, sir, the message is
Yeah.
pretty clear, sir.
So the predicament remains thrombogenesis versus bleeding.
Yes.
It must be a common, shared, informed decision with the surgeons or the oncologist. Neurocritical care, generally, other specialty ICU patients, we are comfortable, but when it comes to neurocritical care, we always discuss, and we discuss seriously with our colleagues that this is the risk. Are you comfortable in starting? Because the risk of bleeding remains high. At the same time, we have to look at the long-term outcome of the patient. If the long-term outcome could be hampered, secondly, because of bleeding, we must again take a wise decision and not be over enthusiastic with prophylaxis. At times, bleeding will kill the patient much before. So we have to have a fine balance, especially if the outcome is poor. So now comes the end, and when cure fades, care begins. How early should end of life care decisions be initiated in malignant brain tumor patients in ICU? Anyone can answer.
I think probably it should be initiated as early as possible, sir. Like probably like if the patient
Yeah.
is only conscious, if he can be involved the decision process, probably if we can initiate early, it will be quite easy for us to convince uh, the family as well, rather than like taking a late call
Very,
will not be a problem. I feel like it has
yeah,
to
yeah, very
be
right, very right.
considered as early as
Yeah,
possible. Once it is like it is non-resectable, highly malignant,
yeah. So whenever we have, sorry,
of course you have to take the other factors. Yeah. And of course, you have to take the other factors into account as well. So like your advanced age, he has got already moribund patient, like uh, uh, the ICP is very refractory to medical management, like not a candidate for surgery. In these set of situations, I think probably it is better to get early on end of life care. So,
So while we discuss the goals of care in a patient with CNS neoplasm, we must also discuss about the palliative care with the patients, end of life care. What happens most of the time, the end of life care decisions are taken very late. When the writing on the wall is clear, patient is on two vasopressors or refractory ICP, pupils are fixed, probably we are already late. So if we want to give quality of end of life care, the decisions must be taken and implemented early in the course of, not after 7 or 10 days of ice to stay, when the patient and the family has exhausted all their financial and other resources and they are emotionally drained out. So early discussion, early goals of care to be defined with the family, and then we arrive at a common care plan for the family. Yeah. Dr. Lalita madam,
Uh,
from
Sorry, so
survival,
just a
yeah,
small
please
thing.
go
I
ahead.
know it is. There's also some cultural these things. Like we know I have a lot of families who come and say, "Oh, don't tell anything to the patient. Don't whatever you want to tell, you tell to us." But we also have to understand even our society has evolved a lot, and a lot of people, well-educated people, want to take the decision about their lives. So a lot of people want to say that I don't want to be on a ventilator. A lot of people want to say I want to go home and die at home, or die in my village, or die within my with all my family members holding my hand. So all those things, like Dr. Gopinath said, that if you have a educated family, or you have the patient himself knows what is in store for them, unfortunate is the situation going to be, I think they should be involved while their cognizance is intact, and take their opinion as well early, and and document all these things.
We must provide them a good death if the chances of salvageability are less. So, from survival to meaningful recovery, we should be measuring the right outcomes in neuro-oncology patient. And as we discussed, the metrics of outcomes should not only be on survival, on organ function, or 6 months survival, and we must look beyond mortality also. Mortality is easy to count, but it is often the least complete outcome. If you look at the death rate, it is the least complete outcome. We should also measure neurological function, cognitive recovery, communication, independence, and ability to resume cancer directed treatment if required. Family burden, symptom control, and quality of survival deserves equal attention in neuro-oncology patient. A survivor who cannot interact, decide, or recover dignity may not reflect our success from patient's perspective. So the real endpoint in neuro-oncology critical care is not mere survival, but meaningful survival. Quality of life or quality of death, both have to be maintained from our side. At the end, I like to request Dr. Das to give the concluding remarks and one carry home message from both of our moderators.
Actually, before Dr. Das says, just about this little thing that we have a lot of small indicators that assess motor function, cognitive function, this thing. But it's very unfortunate that when the clinician, because the patient himself can't speak if he's deteriorating, can't say how tired he is, can't say whether his sleep is getting disturbed, if his cognitive is getting impaired, he can't recollect stuff. So all these things, I think a lot of what really is happening to a patient who's deteriorating, it's very difficult to capture it, because the patient actually can't tell what is happening to him, and so the relatives can only probably tell him that what burden is increasing for them. So I think it's a lovely question that you have put, that it's just so important for these patients when they go home, as to how well they can recover. And I think this is one ICU where your physiotherapist and your nutritionist and your the psychologist or psychiatrist really can do
Thank you,
wonders.
madam. Dr. Gopinathan.
yeah, at the end of the day, I think we need to give them a good quality of life, so like, irrespective of the outcome. Like even if it's going to be end of life care, it should be a quite dignified and good quality of end of life should be given to these
True.
set of patients.
Very good. They should take fond memories. Life or death is different. They should take fond memories around the ICU. Dr. Das, the concluding points from your side.
Regarding the last question, when to start palliative care and when to start end of life care, there are two. It's a different thing. Palliative care should be started from the day one. It is a comfort care, symptoms care. It rely on the principle that treatment should not be torture. So there is no doubt that, and it is not only in the onco ICU, in every ICU, the palliative care should be started in day one. Regarding when to start end of life care, if the clinical pictures are clear that patient not going to survive, and if we are in the same page, everyone, like patient, the surgeon, and then there are no doubt we should start early. But sometimes many a time where we don't agree, and then they think differently, we think different, surgeon they think differently. So nowadays we have a concept of time limited trial, ICU trial. So we can try time limited ICU trial for a definitive period for 4 days or 5 days. They are they are mainly actually tried in hematological cancer, and also they have been also tried in solid tumor. There is no studies about the cerebral neoplasm, but this also can be applied in the patient with central neoplasm. And we can try for a period of 4 days or 5 days, whatever. Then we can after that we can transit to the end of life care. So I think this is my what I might take.
Thank you, Dr. Das. You can give the concluding and closing remark, Dr. Das. We'll close. Thank you, Dr. Mitra, Dr. Gopinathan, and Dr. Das.
Thank you,
Thank you,
Dr.
sir.
Yash.
Thanks.
This was
Yeah,
Thank
very,
you.
very, very nice
Thank you,
discussion. Very
madam.
nice
yeah,
discussion.
Dr. Das, thanks. Note of
yeah,
thanks from your side.
yeah. Thank you, Dr. Gopinath, Dr. Alzi, and Dr. Mehta. It is quite a uh, like enlightening session for me,
Yeah,
and
for
Dr.
all
Yes
of us.
for moderating this session. Thank you so much. Thank you.
Thank you, everyone.
Thank you, sir.
Thank
Good
you.
night.
Good
Thank you,
night.
sir.
Good
Thank
night,
Bye, sir.
everybody.
Bye.
you.